can't see my face today. I had a sudden power outage right before I started up my computer. So thank you to Deborah for adapting really quickly for me, and hopefully we can still engage in a different way. I think that's our virtual world now that we're getting used to. So I am the Education Director for the National Network for Oral Health Access. We are so excited to be here with all of you today, and thank you to the Vermont Department of Health for reaching out to us. What we'll be talking about today are dental sealants and how to prioritize them, place them in the COVID-19 world, and the evidence base behind them. Next slide. So this slide is just lists out the objectives for today's presentation. We'll understand the evidence and the latest clinical guidelines for sealant placement in children, learn a little bit about the latest HRSA and Haynes data on dental sealant placement prevalence, and also describe some clinical strategies for placing more sealant. Next slide. So this slide is just a little bit about our organization. So as I mentioned, I am with the National Network for Oral Health Access. We call ourselves NNOHA. We are a national nonprofit organization that was founded in 1991 by a group of federally qualified health center dental directors who found a need for leadership, support, and networking. And so NNOHA was founded on the principle of supporting dental team members and community health centers to increase access to care for underserved populations. Our membership now exceeds 5,000 dental providers, dental team members, partners, and beyond. NNOHA also receives a grant from HRSA, Bureau of Primary Health Care. We are the oral health training and technical assistance partner for HRSA, and so we have activities that are free to all throughout the year, focused on increased access to care, oral health equity, and dental sealants. So I have our web link there if anyone is interested in investigating us further. Pictured there on the right is Dr. John McFarland. He is the founder of NNOHA. He's a dental director from Salud Family Health Centers here in Colorado, which is where NNOHA is based. And you can tell this was so long ago because there's no PPE, definitely before the COVID era, and I think the hair also gives it away. Next slide. So this slide here is the life cycle of a molar. It is from the American Dental Association back in 1991. And it's an interesting slide because it talks a little bit about the progression of someone's permanent molar and what could happen if you get decay. And so we're looking at the 6 o'clock molar at the bottom. That's where it begins, and that's a newly erupted molar, healthy, no decay. And then over time, if you get a cavity, then you get a filling, and then that filling needs to be replaced. And so you take away more tooth structure and more. And so eventually you're in a crown, and maybe that crown fails, and then that tooth is extracted or replaced somehow. Or and so not only is this something that we see just with traditional methods of prioritizing restorative care over preventive, but we also see a large cost burden on the patient. So as you progress in the life cycle, it's more and more expensive for the patient to maintain that molar, but then it's also difficult to keep it clean. So with the larger filling, you may not be able to clean it as effectively. There may be more debris captured there. And then certainly with the crown, we all know that it's difficult and can also have some other implications like perio. And so thinking and considering this, what could we do to help prevent this life cycle for every molar in all of our patients? And so then we lead into the question of dental sealants. Next slide. This slide is the 2008 and 2016 Journal of American Dental Association guidelines, and they released these guidelines around dental sealants, and there are really three main things to capture from this. First, sealants prevent cavities in permanent and primary molars. Second, sealants can prevent the progression of early non-cavitated carious lesions. And three, that resin or glass ionomer sealants have been found effective when has when they have proper retention in preventing caries. So these are three main points that we'll discover a little bit deeper today. One thing to note is, if you're able to place sealants, maybe at that first cycle in the life cycle of the molar, perhaps we could delay or prevent that tooth from having to get into that crown stage or having even a filling if that sealant is placed properly. And it really does protect the patient. But then also number two is something of a mind shift for a lot of us dental providers. Sealants can prevent the progression of early non-cavitated carious lesions. So what does this mean? Let's look into that a little bit more. Next slide. First, this is also from the American Dental Association. It's just a little infographic that talks a little bit about dental sealant. So if 100 children did not receive sealants, 50 of them would end up having cavities. But if you did place sealants on 100 children, well, 50 of them would not have cavities because they wouldn't have anyway. But of those 50 that normally would have gotten a cavity, only 12 of them would have, and 38 would be caries-free because they had a sealant. So what that means is that you're potentially able to save 38 out of every 100 kids from a lifetime of restoration, repairs, and that means an increased quality of life and also preventing those costs for the patient. Next slide. So this is from the International Caries Detection and Assessment System. So it's a scale of dental caries and like the severity of the caries. And so if we look at 0, that's a sound tooth that does not have any carious lesions. And then 0 to 4, these are considered non-cavitated carious lesions, meaning that there is not a cavity, meaning a hole in that tooth yet. So you can see the images there. And then severe decay, 5 and 6, those are considered cavitated lesions. Those lesions need to be restored surgically, removing tooth structure and replacing it with a filling material. But if you look at 1 through 4, so do not have holes, and based on the guidelines and the evidence that we know, you can place a sealant on top of these lesions, and it would prevent the progression of the carious lesion and prevent that need for restoration. And so this is kind of a different thing to think about. I'm a hygienist myself, and I remember being in hygiene school and knowing, and you'd go and the dentist would come and check the tooth if it's okay to seal. And a lot of the times it was, let's just watch it. But in reality, you can place a sealant on top of these areas, and that would probably be a benefit for the patient. I think there's a dentist that I know who has said, if you let's just watch it, might mean let's just watch it get a cavity and get a hole in the tooth. And I don't think that's the right perspective if there's other ways that we could potentially treat that tooth. So next slide. What does this mean? Where is the data for this? So this slide shows a lot of different evidence-based journals and guidelines that validate the guidelines from JADA that sealants are effective in preventing decay, but they're also effective in preventing the progression of non-cavitated carious lesions. So it's something to investigate as well. And one thing to note is that this evidence is not new. These are guidelines that have been presented for years and years, and you can see some of the dates for some of these articles back in 1976. This information was published, and so it's not new, but it is certainly a change in mindset for us dental team members. Next slide. This slide is from Clinica Family Health that they adapted from a Pits and Zero article in 2015. Clinica Family Health is a health center in Colorado. And what this table does, it describes the level of evidence for different modalities for the primary and secondary prevention of caries. And so we're talking about preventing caries altogether or being able to remineralize and arrest the caries. So the lower on the table, the less amount of evidence there is available saying that these are effective in primary and secondary prevention. So we're looking at non-fluoride remineralizing agents, antimicrobials, diet modification leading up to fluoride being the number one modality that has the most published evidence when it comes to
Oh, yeah, you saw it in here.
When it comes to primary and secondary prevention, second being dental sealants. Now, one thing to look at on this graph on the far right table that says examples, the things in green, the things in green are what require patient compliance in order to be effective. And so, for example, salivary stimulation like xylitol or sugar-free chewing gum, you're relying on the patient to chew that gum on a regular basis in order for it to be effective. Same with diet modification. The patient has to leave the appointment and actually adhere to behavioral changes, changing their diet or using fluoride toothpaste, fluoride mouth rinse. And so there's some caveats there, because if the patient is not going to be utilizing these things at home, then it's not effective. The only thing on this table that does not require patient compliance after they leave the chair is dental sealants, because you place the sealant and then that's it. They leave the appointment and they're done. And so obviously they have to be compliant in the way that they're coming into the chair to get the sealant. But once they're there, there's nothing else that needs to be done on their end. They can go home and then that sealant works for them. And so when you think about your patient population and what may be the most effective, perhaps consider dental sealants, because a lot of the times we're talking about children who, I have a 2-year-old and she's wild, and it's difficult to say that they're actually going to do and follow what you tell them to, and it requires that additional caregiver support to make sure that they're going to brush effectively, that they're going to change their diet, use the fluoride toothpaste, those type of things. And so dental sealants may be helpful, and especially for our children who may not be as prioritizing of their oral health compared to maybe an adult. Next slide. Actually, if you'll go back to the slide on the table, one thing I also want to note here is if you look at this list, a prophylaxis is not listed here, and that's because there is not evidence that says that a prophy prevents caries at all. So another thing to think about. Next slide. So this slide, wash or seal, you can wait and then a cavity may happen, and this slide kind of shows that life cycle of the molar in real time, or you can apply a sealant and then hopefully, so long as that sealant was placed effectively and given other circumstances, that a cavity would not happen. And so if the patient is sitting in your chair, has a little bit of staining in the grooves, you can still place the sealant and be comfortable knowing that that patient is less likely to come back with a large hole in the tooth. Next slide. So a lot of concerns that come up when we talk about this information. What if I inadvertently seal the tooth and seal decay into the dentin? So there are really a couple trains of thought here. So what if I seal a tooth that would have normally been restored, and then there's a cavity in there and it was in the dentin and you didn't see it in the x-ray, and now it's full-blown cavity. First, is the patient unlikely to see the dentist again in the next 10 years? If so, then the outcome really is unknown. Based on the evidence, they tell us that a non-cavitated carious lesion can be sealed over and can help arrest that cavity. And so either you can say, we'll just watch it and then they'll come back with a full-blown cavity, or you assume and follow evidence that the sealant will help arrest the progression of that cavity. For all other patients that will in fact come back into your chair, there are plenty of opportunities to arrest the caries and the rare likelihood that the sealant is not effective. So they are coming back in 6 months and you did seal over, if you take a radiograph at that point, you'll see that, and then you'll have the opportunity to address that carie. And so I think it's important to think about what benefit outweighs the risk. And if you are able to arrest a cavity, save that patient the time, the money, and the pain of that tooth progressing into a large cavity, then we should. Next slide. So this is an article from 2015, and it just talks a little bit about the carious lesions under the surface of sound sealants over 44 months. And what's really interesting is that regardless of the lesion severity being non-cavitated on that level of 1 to 4, sealants were 100% effective at 12 months and 98% effective over 44 months in managing occlusal caries at that scale of 0 to 4. So it's really interesting to think about here. If you are concerned about sealing over a non-cavitated carious lesion, the evidence tells us that the likelihood of that tooth progressing is actually quite low. So what happens to the sealant or the molars that have lost sealant? The sealant fell out. What happens there? Again, evidence tells us that less than 13% of those teeth will develop Denton caries within 3 years after losing that sealant. Also, it tells us that teeth with resin sealants had 4 times as many lesions in those with glass ionomer. That could be because glass ionomer does have some fluoride in it that is releasing even after placement. And then some electron scanning reveals that glass ionomers reveals that there was glass ionomer material in the deep fissures of the occlusal surface even after the sealant was lost. So visibly you see it and it's not there on the surface of the molar anymore, but they did find some remnants of glass ionomer within the fissures of the tooth. Some caveats for this to always consider with articles is that they had a lower than expected resin retention. They used a specific type of glass ionomer sealant material, high viscosity, and then these children were low to medium caries risk. Next slide. So this graph is the NHANES data from 2011 to 2016. It's the prevalence of caries in permanent teeth ages 6 to 11. And you can just see the prevalence of cavities in permanent teeth. In general, it was higher in Black and Mexican children compared to Caucasian white. And there was also higher in with those who had a lower poverty level or higher poverty level. Next slide. This is the prevalence of dental sealant in that same age group. And you can see that the white children were more likely to have dental sealants compared to Black or Mexican American. And also those who were above federal poverty level were more likely to have sealants as well. And so even though the risk tells us that lower or those who live below federal poverty level, and then those who are Black or Mexican American or are in other persons of color are more likely to be at risk for caries, and they're not the ones getting the sealants. And so it's something to think about as well in your practice, that if your population is more of this high risk group, what can you do to increase access to care to make sure that those patients are getting the same prevention as the other? This is the UDS sealant measure. So the UDS, if you're not familiar with it, is a HRSA measure. It's called the Uniform Data System. Any organization like a health center or a lookalike that receives funding from HRSA has to report on a specific set of measures every year. The only oral health measure is dental sealants. And so dental sealant, what the measure is dental sealants for children 6 to 9 who are at moderate or high caries risk, who received at least one sealant on a permanent molar. So when we're thinking about the age group 6 to 9, we're really only talking about the first permanent molars. And so this is the evidence over, or the data over time. And so you can see that there was a nice progression from 2015 to 2019, and then COVID hit. And so then 2020 happened, and here we are, that we dropped down from 56% of these children getting at least one sealant to 48% in 2020. And one interesting thing to look at here is in Vermont in 2020, they were below the national average, but the yellow line shows the 2021 national average. And I apologize, it's like last final bar doesn't have the correct label, but that final bar, that 67%, is Vermont in 2021. So that shows us that health centers in Vermont in 2021 placed far more sealants than they did in 2020, which is great. But then also that the sealant measure, they exceeded the national average. And so there's been a bit of a bounce back from COVID, which is great, but still a lot of room to grow as far as patients getting sealant. So that UDS data showed us our first indication of how COVID impacted sealant placement. And so some of the general impacts that we've seen and sorry if I didn't say next slide, it's the impact of COVID-19 on dental sealants. School-based programs temporarily closed, as many of you know. Also, there was a reduction in aerosol generating procedures in a lot of dental clinics. So that was a lot of preventive things like prophies and then also dental sealants. And there, of course, was limited staffing. We saw a lot of individuals being laid off, furloughed, or just leaving healthcare in general. And so there is some workforce strain and less time to place sealants. And that could be, again, because of the limited workforce, but also there's increased PPE and infection control that we're having to manage now. And so that takes time during the appointment. And so you may have less time to place the dental sealant. So then that kind of goes on the back burner maybe. And then also just seeing in general that as we started to reopen clinics, that there was a huge influx of patients who had not been seeing a dental team member or provider over the last year or more. And so now schedules are really packed and flooded. Next slide. So despite all of these things, however, as we've seen from the data, it's important to still prioritize dental sealants and perhaps prioritizing them for those who are at high risk for caries, especially children, because that is more beneficial to the patient than doing the prophy, as we see that prophies do not prevent caries, although they can definitely be helpful when it comes to perio or things like that. We're not looking at perio as the #1 childhood disease in children. It's caries. And so what can we do to prioritize evidence first? So it's difficult to want to place sealants during COVID since we know that they produce aerosols, but there are a lot of things that you can do to help reduce the amount of aerosols generated during sealant placement. So these are some things that we've seen with clinics across the country that they've implemented as innovations to be better able to place sealants while minimizing aerosols. And so instead of rinsing and polishing the tooth, which creates all that water splatter and whatnot, some clinics have been giving patients sugar-free gum to chew and then spit out to remove some of that occlusal debris. Others have given patients a dry toothbrush and asked them to go into the restroom and brush their teeth before they come in. And then you can also use like a Q-tip, cotton roll, or gauze to wipe away debris. Of course, if you have a patient that comes in that's really heavy plaque, these things may not work anyway. And so thinking, of course, if you need to do the prophy first, of course you can. Other things that we have seen with clinics that using isolation equipment to suction while placing the sealant. And then you can also consider glass ionomer sealants. Glass ionomers produce minimal aerosols because the seal does not need to be completely dry. And so if you're able to remove the debris off the tooth effectively and then place the glass ionomer, you're probably going to produce very few aerosols compared to the traditional resin sealant. So what are some things we can do to close that gap? And so closing the gap to make sure that the other 60% of patients are getting sealants. It's going to require a little bit of disruption in our mindsets, prioritizing procedures that prevent caries, and that's the next slide, I'm sorry, disruption, that prevent caries and future aerosol generating procedures. We also would need to eliminate or reduce the non-essential aerosol generating procedures for patients that are high risk for caries, like the rubber cup prophy, and just realizing that sealants are more important than ever. We've had a large group of children that probably weren't coming into the dental clinic or not getting dental care through school-based programs because of COVID. And so it is likely that you'll see an increased rate of caries in children. And so being able to provide that prevention when possible is great. Next slide. So now we're at the green slide, top strategies to place more sealants. So these are strategies that have been tested since 2015. NNOHA has been providing training and technical assistance to health centers and dental programs across the country on dental sealants since the release of the UDS sealant measure, which was in 2015. And so these are things that have been tested to help increase sealant rates within different practices. Next slide. So the first one is number 6, treatment planning sealants. And as mentioned, sealants are more important than ever. And so if you're able to, like you do a filling or something like that, treatment plan the sealant. So that way it stays top of mind and it's something that you want to complete. If you're tracking things like treatment plan completion, that would be the way that you could maybe get some more sealants placed, as health centers would try to prioritize that a little bit more. Next slide. This is a slide that just shows a bit of evidence from the 2018 and 2016 evidence-based guidelines, and just shows some specific systematic reviews of randomized controlled trials. And in the 2008 and 2016 guidelines on dental sealants, the sealant guideline panel recommended the use of sealants compared with the non-use of sealants in primary and permanent molars with both sound occlusal surfaces and non-cavitated occlusal carious lesions in children and adolescents. So again, kind of driving home the need and the importance of prioritizing sealants and the evidence telling us that it's okay to place sealants on sound occlusal surfaces and the non-cavitated carious lesions. Next slide. These are just some pictures of what non-cavitated carious lesions will look like. This might be something to share with your team if it's something that you want to pursue a bit further. Next slide. Number 5 is equipment and materials. So utilizing different things to help make sealant placement a bit more efficient. So the picture on the left, this is like an isolation tool like IsoLite or IsoDry, and it suctions the tooth. So it, as I had mentioned, this is something that a lot of clinics started using because of COVID to help minimize aerosols. But also, if you don't have an assistant to support you to help retract and make sure the field stays dry, this is a great way to do it. Other things to consider are faster curing lights. So if you're using a light that takes 30 seconds to cure one sealant, you may think about looking at one that takes maybe half the time, 15 seconds, and that might shave a little bit of time and allow you to place one additional sealant. And then in the middle is the Fuji Triage, which is the glass ionomer sealant material that you could also use that would maybe make it a bit faster to place sealants, because again, it doesn't require the field to be dry, and so eliminates the need for that section and rinsing that you usually would have to do with a resin sealant. Next slide. So this is, I have 3 polling slides, and we don't have the poll active, so you can ignore all the text at the top. But what I'd like for you all to do is to put into the chat box your response. How fast is your curing light for sealants? 0 to 9 seconds, 10 to 19, 20 to 29, or more than 30 seconds. So let's take a second to do that. And then Deborah or someone from the team, if you could just give me a general idea of the responses that you're looking at.
Please go ahead and enter your responses on the chat. 20 seconds from someone. 0 to 9. 19 to 29. 10 to 19. 20 seconds. 10 to 20 seconds. Yeah, seems to be a wide range, a lot of variation here. 20 seconds.
Okay, great.
Yeah, mostly 20 seconds. I think that's been the most frequent response, 20 seconds.
Yeah, and I think that's pretty standard. I haven't seen a ton of curing lights that cure in less than 10, but if you're at more than 30 seconds, or if you feel like 20 to 29 seconds is a bit long, you can think about switching to a faster curing light when it's time to replace them. So the next polling question, next slide. In my practice, when we place sealants, we use all the following isolation techniques. And what you can do is let's label these A, B, C, and D. So A being an all-in-one isolation device like Isolite, Dry Shield, something like that. B being old school cotton roll holders and dry angles. C, cotton rolls held down with your fingers, or D, a rubber dam.
Got 1A so far. 1B, 1A, A and C. B. Seems like A's seem to be popular. And then 1B and a couple C's. Yeah.
Okay, great. I do find that rubber dam is pretty uncommon. If you do have a patient with a rubber dam for some reason and they need a sealant in that field, go ahead and place it while they're sitting there in the chair. But isolation, dry shield, all of those things are definitely things that we've seen heightened because of COVID. And so again, just things for you to consider if you're looking for better isolation and reducing aerosols. Next slide. So this is our third polling question. Right now we use the following sealant materials. So we have resin only, glass ionomer only, or you're using both depending on the clinical situation.
We're doing A, B, and C for those as well, Candace?
Sure, yeah, let's do that, A, B, and C.
Oh. Someone said, please, glass ionomer only. Then I have A, but we'll be switching once our supply is gone. So some people are switching to glass ionomer. I got a couple people saying resin only, and then one person saying glass ionomer only. A couple more for resins.
Okay, great. So a pretty good mix there. And of course, I encourage you all to connect with each other. If you're thinking about switching to glass ionomer, it's always great to talk to another clinician that is using that too. Glass ionomer, again, is something that has started to emerge because of COVID. It's a lot easier to place it without producing any aerosols, but of course you can use it based on clinical situation. That just means that you have two different materials on hand, and there are some great resins out there now that are like wet bonds. So they can be slightly wet, but it's still like needs to be somewhat dry. Next slide. Okay, so this slide is directly from GC America. They did a webinar with us early in the pandemic about how to place glass ionomer sealants in the COVID-19 world. And so this slide, print it, take it with you, look it over. It tells you the step-by-step guide for how to place a glass ionomer sealant. And so as you can see just from the pictures alone, no sectioning, no rinsing required. You just identify the tooth that needs to be sealed, remove any plaque or debris from the surface, apply some cavity conditioner, and then you place this, the glass ionomer material and press it down in the occlusal surface with a wet finger, and then you just let it set. And so it can easily be done with very little materials, but also easily be done while reducing the amount of aerosols. One thing that's good about glass ionomer, again, is that you could place it on teeth that are hard to reach, that may be partially erupted and cannot stay really that dry. And so a lot of great things that can come from glass ionomer, but not a lot of great evidence on the retention. So I think there are things that definitely need to be tested in your own practice. Next slide. Some considerations for glass ionomer: they can be placed without a dental assistant. Go ahead.
Oh, Candace, I'm sorry, that's me. That's Deborah. No, I just wanted to mention that we on the 802 Smiles website, we have posted the recording to that webinar, Candace, that you referred to, the sealants in a COVID world from NNOHA. It's an excellent presentation, and it's available on the website as well, on the 802 Smiles website. Sorry, Candace, go ahead.
No, that's great. Thanks, Deborah. That's great. Other considerations is that it is a learning curve. Most of us learn how to place sealants with resin material, so it takes a bit of an adjustment, but it's not hard. But you will need some additional training to learn how to apply them effectively. We hear a lot of people tell us, oh, I'm not using glass ionomer because when I did it, I didn't feel like it was retained very well, or it wasn't there when they came back. And so it requires some training on how to do it effectively, because a lot of time it's user error, or they weren't pressed down hard enough, things like that. And so I encourage you to try it, to test it, call up a rep that is supplying your glass ionomer material and have them come and do a training with you or talk to you about it, because it's worth a shot, especially since COVID is here to stay. And if you can do what you can to help produce that aerosol, that's great. It helps increase your provider and your patient comfort level. But also there are some benefits. Everyone has that patient that comes in that has like the perculum like right over that surface, and then it's not dry and it's impossible to place a resin. This could be that solution for you. The field can be moist, as I mentioned. It's helpful for areas that are difficult to isolate. And if you're starting up a program and you need minimal materials or equipment because of cost, a glass ionomer is a great route to go. Really, all you will need is some gauze, cotton rolls, the material, and something to retract the cheek or the tongue. And so this could be a mirror or even like wooden tongue depressors. So if you're looking at creating a program, or maybe you're in a setting that you can't have all of your materials and supplies, glass ionomer could be a good opportunity to do that. Next slide. This is that webinar that Deborah just had mentioned, and it sounds like it's on the 802 Smiles website that you could hit up instead, but we also have it on our website. It's just the link to the recording as well as the slides. And so it's a great resource to look at for sure. Number 4, next slide, is workforce. And so utilizing your workforce to the top of their scope. And when we think about workforce, we're really talking about dental hygienists and dental assistants. And I have highlighted there a little line that talks about the arrow, and that's Vermont. And so actually a lot of the colors in this little color wheel are filled in Vermont. This is for dental hygiene scope of practice, and that's great because you do see a lot of slides where there's no colors filled in, and so that's a very limited scope for dental hygienists. But what we're looking at in this color wheel, this wheel may be slightly out of date, so take this for a grain of salt. They haven't updated it in a while, but it's the yellow color, and if that color is filled in, at that time, hygienists can place dental sealants in a public health setting without prior approval of a dentist. And so that means that you can place sealants on the teeth without needing an exam first. And so that is helpful for time, but also great for other public health settings like school-based settings and things like that, where you may not be able to have a dentist there to do an exam. And so you can be able to place sealants. Now, for some dentists, that might be a little concerning. And what I would say is trust your providers, trust your team, because it won't work effectively if you can't. And so do some competencies, talk about what teeth can be sealed, what teeth can't be sealed. And as we are seeing that anything on that 1 to 4 scale, a tooth that is non-cavitated, you can place a sealant over that. What is the comfort level of the supervising dentist to be allowable of that? If your dental assistants can place sealants in your state, another thing to consider as well, a great use of time using a dental assistant in your clinic. That way you don't have to wait for the hygienist or you don't have to wait for the dentist. If you're only using a dentist to place dental sealants, really reconsider. Utilizing dentists to place sealants are not a great use of time. It's not cost effective, and there are far more other things that they could be doing at the top of their scope that would create better use of the patient's time, but also your provider, and probably increase staff satisfaction a little bit. And so if you're able to leverage your whole team, I think that is a great strategy. Next slide. So this is another polling question. Feel free to do A, B, and C in the chat box. In my practice, the following team members place sealants: only your hygienist, only your dental assistant, or both.
So please enter. I got a couple of both. I got one A, one more C, both. Anybody else? Oh, hygienist and F does, expanded function dental assistants.
Okay, that's great. It's good to see that some of you are utilizing both, or a dental assistant, expanded function. And so just thinking about how you can leverage your whole team, I think, is a really great way to approach sealant placement. Next slide. Number 3 for increasing sealant rates is developing standardized sealant workflows. And so this is just an example of workflow that was created by a clinic, and putting sealants into the workflow of an appointment is good because it helps keep the team members top of mind on sealants, but also allows them to understand how the appointment flows, when should a sealant be placed, at what point of the appointment, and things like that. Next slide. So this slide here is prioritizing sealants over routine restorative care. And so this slide was shared with us from a health center that was trying to, shift mindsets of their dental team members. And so if you look at the left side, where it has 6 visits. So traditionally what they may have done is bring the patient in for an exam, x-rays, prophy, and fluoride. And then, oh, you have these cavities and all these things, let's bring you back. So then they come back for a second visit, do restorative care on the lower left, and then they come back for a 3rd visit to do restorative care on the lower right, and then a 4th visit to do a lower lingual arch, 5th visit to do their recall appointment in 6 months, and then they say, oh, now that we have you here, let's go ahead and schedule you to come back to place some sealant. And so then they come back for a 6th appointment to seal number 19 and 30, but unfortunately those teeth have cavities now, so you can't place a sealant. So as you can see in this traditional way of prioritizing restorative care, the patient ended up getting cavities on their permanent molars, and they also had to come back 6 times to get that all done. But if you can change mindsets a little bit and maybe prioritize prevention first, we'll go to the right side. They come in for that 1st visit, they get an exam, x-rays, talk about education, and then place the sealants on 19 and 30. Because if you look at this picture, they're nice and sound, no cavities. So go ahead and place the sealants there. And if you have time, you can do some SDF on any of those teeth that are possible, or the prophy and fluoride. Then they can come back for their 2nd visit, do some restorative work, extractions, and fillings for a 3rd. You may add an extra visit if you want to still do that lingual arch for the spaces, but ultimately what we're seeing here is if you were able to prioritize sealant placement over restorative care, you could potentially prevent their permanent teeth from getting cavities. And so if you're able to prioritize the sealant during the first visit, that is ideal, and you will in turn place more sealant. Next slide. The number one strategy that we have seen that has been the most effective in increased sealant rates is same-day sealants. And so this means if the patient is in your chair, you're going to place a sealant instead of rescheduling to come back. If you reschedule them to come back, what you're doing is increasing the risk of them no-showing or you needing to cancel the appointment or something like that. So then they won't get the sealant placed. And I would say that in general, a lot of parents and patients do not know a lot about dental sealants, but they know about the cleaning. And so if you don't have time to have them get their cleaning done during the appointment because you're placing the sealant first, they're more likely to come back for the cleaning than they are for sealants because they just don't fully understand the concept. But talking about the importance of them coming back for sealants means they may not come, and then as a result, you may not see them for another 6 months or a year, and that tooth could have a cavity by then. And so if you're able just to do it while they're in the chair, that is the best way to go about it. Next slide. Some best practices for being able to place sealants in the same day. You can do morning huddles or alerts on your electronic health record that identify patients that are 6 to 9 or 11 to 14 who just had their permanent molars erupted or that may be eligible for sealants. Also having sealant trays or ready to go sealant kits curing lights in every single operatory. That way, if you have a patient that comes in that needs a sealant, you don't have to go digging for all the materials. Having policies and protocols within your practice for sealants. So saying that any child that comes in without cavities on a permanent molar must have sealants placed at the exam. That's just an example of a policy that you can put in place so that way your team members understand what the priorities are and what needs to be accomplished during specific visits. As I mentioned, same-day workflow or workflows for same-day sealant. Having embedded providers if you're at all in a clinic where you have primary care at the same site, being able to have a hygienist over there to talk about sealant placement or being able to actually place sealants in primary care. And regular patient education on sealants. I think this is really important. If you have a patient that comes in that's 5 years old, you can talk to them early to say, hey, when you come back next time, we're going to place sealants and that these are what they are, and having that understanding and kind of preemptive discussions about sealants for your team. This is an example of like what a sealant kit could look like in an operatory. It has all the materials and supplies that you need to place sealant. So the last thing I'll walk away with is a lot of times we see that you need to do a prophy or at least toothbrush prep the tooth before you place a sealant. Another strategy to help place sealants faster or to help eliminate aerosols is to clean it in other ways. Sealant, according to these two articles, sealant retention is comparable whether the tooth is prepared by either a dry toothbrush or actual doing of the prophy. And so there's no evidence that a prophy improves caries prevention or the effectiveness of sealants or fluoride varnish. And so if you're able to save time, take a dry toothbrush and kind of wipe off that tooth, use gauze, things like that. Those are things that you can do to help reduce the amount of aerosols in the appointment, but also making sure that you're able to have time to place the sealant. If you need to do the sealant first and then the prophy after, that's fine. It's not going to impact your sealant retention at all. So with that, here's my contact information. Next slide. It's the green slide with all my contact info. And I also included our information for Dr. Irene Hilton. She's Noah's dental consultant, and we tag team a lot of our trainings together. So if you have any questions, either of us are a great contact. So now, next slide, I'm going to move it over to Community Health Centers of Burlington, health center that have participated in a Sealant collaborative with NNOHA, and they're going to share some of their experiences, and then we will then pass it over to another clinic, Notch. So is someone from CHCB Burlington on? Alicia, Katelyn, or Dr.
Yeah, I see Katelyn, Denton, I see Dr. Lasiponara. Yeah, and thank you. Thank you to these health centers who agreed to share some of their, oh, Katelyn is testing her microphone. So I just wanted to say a big thank you to Candace for the wonderful presentation. I mean, we'll have some time to talk about these things. There's a lot of excellent information to digest, take in, and think about and think through, and we'll revisit a lot of these ideas. Thank you so much, and thank you also to the health centers who agreed to present some of their work and tips to increase sealant placement. In the meantime, Candace, is it okay if anyone has a question for you? Or should we wait
Sure.
till the end? How do you prefer to do that?
We can do questions if the team is working a little bit on their audio.
Okay. Anybody has any questions or thoughts, comments, anything? Oh, it seems like Dr. John, you have your hand up.
Yes. Can everybody hear me?
Yes.
Okay. Candace, I think that is the best presentation I have ever heard on sealants, and I thank you very much. And I especially thank you for, everybody can hear me? Okay? Okay.
Yes, you're on. Yeah.
I especially thank you for your talking about glass ionomer materials, because I am a huge fan of glass. And I am not a huge fan of resin at all. And just if I can say, just point out one thing, you mentioned that glass has a 4 times more effective rate in preventing decay if it comes off of the tooth. It really doesn't come off of the tooth because it stays in the grooves, it stays in the pits, and it truly does bond with tooth structure. Unlike unlike resin does not bond with tooth structure. That's a myth. And also, one thing that you did not mention is povidone iodine. There are some really great studies out there. Jeremy Horst has done some really good studies about povidone iodine as a home use for reducing dental decay. And it is very easily used, very safe. It's an essential medicine classified by the World Health Organization and the Food and Drug Administration. But anyway, thank you so much. It was a great presentation.
Thank
I
you.
agree. Wonderful presentation, Candace. And I saw I'll just tell you all just a quick background of how I got to Candace. Fortunately, I was able to watch a webinar with Dr. Irene Hilton, who is Candace's co-worker at NNOHA. And it was a very similar presentation. So I said, I have to contact them and see if they can come to 802 Smiles, because it's like, yeah, just so much important information. And I'm so glad that Dr. Hilton connected us, Candace, and thanks so much for doing this presentation. And as to what Dr. John just mentioned, Dr. John, I have shared with 802 Smiles the article by Jeremy Horst on the iodine use for caries prevention. So we'll have more opportunity to discuss that too. And in terms of trainings for people who want to learn more about how to use glass ionomer sealants, I saw that Dr. John posted a message on the chat that he's open to helping people who need additional training or have questions. So thank you all. And now I see that Katelyn said her mic is working. Oh, so I guess we're ready to go. Katelyn, I have the slides up, so just let me know when you want me to advance, okay?
Test, test. Can you hear us?
Yes.
Oh, yes. Sorry about that.
We don't usually use
No.
Microsoft, so
No
I had to
problem, no
call in
problem.
the IT team. So I
No
apologize.
problem. No worries. Thank you for being here.
All right, well, hello, good morning, everyone. My name is Katelyn Denton, and I'm the clinical supervisor for the Community Health Centers of Burlington. Thanks for having me. As Candace said, I'm just going to do a little presentation on who we are as CHCB and just our efforts to increase our sealant rates within our practices. Next slide. All right, so just a little bit about us. CHC has 3 active dental sites within the Burlington area. Our Riverside location and our South End location, which provides the scope of just general dentistry. And then we also have a school-based dental center, which resides within an elementary school. Our current clinical team is made up of 7 dentists, 4 hygienists, 4 EFTAs, and 6 dental assistants. We do provide preventative, restorative, and advanced dental care. Just a little bit about who we see, our patient clientele. So primarily, we see those enrolled in Vermont Medicaid, though we do have a small percentage of patients with commercial insurance and patients who are full fee. And as you may know, as an FQHC, we also offer some other programs for patients, such as a sliding fee scale for those who are eligible. One thing that's a bit unique about our FQHC is that we are not encounter-based. Next slide. Okay, so this is just a couple different graphs in regards to our Riverside and South End site. So at the bottom there, you can see our total unique patient number for fiscal year 2020 and 2021. And then the pie graphs are representing our payers. And so as I had mentioned, most of our clientele is enrolled through Medicaid. And so those graphs represent that with a bigger percentage. But as I had mentioned, we do have a small percentage of those who are covered by commercial insurance or self-pay. In regards to self-pay, that is those who are full fee, but also those who are covered by our sliding fee scale. And then just to note, the total unique patient number. So for example, the fiscal year 2020, that total patient number will not be the same as the number that's reflected in the pie graph. And that's because a number of our patients are covered by more than one type of coverage. So for example, a patient may have Medicaid, but also be eligible for the slide. So that graph would represent multiple payers for one patient. Next slide. So just a little bit more about our school-based dental center. So our school-based dental center was opened in 2004. And as I had mentioned, it's located within an elementary school. This site functions during the school calendar year. So typically starting at the end of September and then ending beginning of June. This school-based center provides preventative and restorative care for children who attend school within the Burlington School District. And they also must be either enrolled in Medicaid or be low income and uninsured. So within this clinic, we have 3 dental chairs with digital x-ray units and a panoramic x-ray machine. And then something that's a little bit unique with our school-based dental center is we do offer transportation as a service, and it can be provided for those who sign up for this school-based dental center. That is not something that's done directly through CHC. It's contracted with an outside transportation agency. Just for example, because we have a number of schools, elementary and middle schools that are within the Burlington School District, any kiddo that is being seen at a different school, they have the option to be picked up from school, brought to their appointment, and then when the appointment is finished, brought back to school with this service. Next slide. So similar to what you were seeing before in regards to our Riverside and South End site, this is a reflection of our school site. And so again, total unique patients, this is fiscal year 2021, and then just a representation of the payers. Again, specific to this site, children who are enrolled in this program must be enrolled in Medicaid or be uninsured. Next slide. So moving on to some UDS sealant data for calendar year 2019 through 2021, specific to us, CHC. So just a couple benchmarks, the Vermont benchmark, the national benchmark. On this graph, you can see a 330 grant goal benchmark that is specific to the community health centers and grant funding. So that's not something that you'll always see when you're looking at different benchmarks. But just to kind of go over the different percentages and where we were at. So just looking at 2019, we were very close to that national benchmark at 55.96. And then moving on to calendar year 2020, COVID had a huge impact on us as it did a number of offices in dentistry in general. So you do see that percentage dip quite significantly. And then moving on to calendar year 2020, we did improve our sealant rate pretty significantly compared to 2020. And I do believe we exceeded the national benchmark for 2021. Next slide. So just a little bit more on our school-based center, sealant specific. So to give you an idea of what happened to our school-based clinic, it was closed from March 2020 until November 2021. So when we returned in November, we also were dealing with some pretty significant staffing issues. And so when we returned to the school, it was a very limited schedule. So although these numbers, are low, we did do a good job seeing kids and getting kids in and placing sealants. So we did see 74 kiddos who had sealant placed, and out of that group, 74 kids, 518 sealants were placed. And that was during our limited school year from November to May. Next slide. So as Candace had mentioned, we were part of the Sealant Learning Collab. And so a lot of the things that she spoke to, we have tried to implement here or within our clinics. And so some of those strategies that we have been able to implement to increase our sealant rates start with same-day sealants. So that was something that we primarily focused on at our school-based dental center. And I do think we succeeded, even though we were there at our school limited. I do think the limited time that we were there, we did make a big impact. And so that's something we want to continue to do, not only at our school-based dental site, but we want to try to do that, implement that at all of our sites. Something else that we focused on was utilizing our FDAs and our hygiene team to place sealants. We outfitted our dental ops with ISO dries. So, prior to COVID, we did have the ISO dry isolation system in some of our operatories, most of our restorative operatories, and curing lights available in those ops, but we were able to outfit most of our operatories with the isolation system and curing lights, which in hopes would encourage providers to do same-day sealants. It would cut down on prep time and having to search around for equipment to use. And so we were able to do that at our main site. And then another thing that we made a change with was our sealant material. We moved to a hydrophilic fluoride releasing sealant material, which requires no bond. It is light cured, but it also is much more tolerant of moisture. So far, our providers are liking this material. You know, it doesn't require bond. It is a bit more tolerant of the moisture. So far, we are liking this material. But as we continue to use it, we'll see the results of, you know, how long these sealants are lasting. Are they returning to us with sealants? And that will give us a better idea for the future and the product. Go ahead, next slide. Just a couple of our current challenges and past challenges. So our biggest challenge right now is our staffing, and that has been pretty steady since returning from COVID. And so the biggest challenge right now would be with our hygiene team. We currently are experiencing a hygienist shortage, but we also are having a hard time with recruitment for dental assistants. That is significantly hindering our school-based dental center schedule. So prior to COVID, we were able to be in the school between 4 and 5 days a week, running 3 chairs. We currently are only able to, with our current staffing, only being able to be in there at most maybe 2 days a week, and most of the time running 1 to 2 chairs. Another challenge that isn't in particularly new, but it is very evident. There's been a decrease in students enrolled in the Burlington School District, which then affects the number enrolled within our school-based dental center. And then some past challenges, I put this in because we definitely have tried to make changes and overcome some of these challenges, but just listing these two, specifically the lack of flexibility within provider schedules. I know Candace kind of commented on this. We've had some progression with rigid, with providers being very rigid with what can be done in schedules. And so trying to get our providers to be more flexible with those schedules and what can be done in those same day appointments. And then of course, as I mentioned, our school-based dental center was closed from March 2020 through November 2021. And next slide. All right, so just on to some future plans and goals to increase our sealant rates. So still really focusing on same-day sealants. We would like to start implementing that with our hygiene schedule at our school-based dental center. As I noted before, we are limited right now with our hygienists, and so we are going to plan to start that process at our school-based dental center. When kids do come from their appointment for their cleaning, doing the sealants at that time as well. One of our other goals is to hire a school-based dental hygienist who primarily works at the school site. We did have this job role previously, and this is something that we probably won't see anytime soon just because of the limited schedule at the school, but that is a future goal of ours to get back into the school full time. And when we are able to do that, have a dental hygienist who works primarily at our school. Another goal, block scheduling, flexibility within provider schedules. Also hiring providers who have experience and interest treating children. I guess one of our other past and current challenges is we do have providers who do not see children. And so if a child is seen by one of those providers, most of the time, same day treatment is not getting done. So block scheduling would help with that, but also making sure that those who we onboard have experience and interest in treating children as well. Prioritizing sealants over basic restorative with our high-risk child population. We're currently doing some of this, placing SDF same day, but I don't think we're prioritizing sealants as much when there is, you know, basic restorative to be done. So that's something we could work on. And then just to continue to equip all our sites with ideal isolation equipment, encourage, you know, providers to do more in appointment. And then of course, once we're fully staffed, return to our school-based dental center full-time during the school calendar year. And next slide. And that is it. Does anyone have any questions?
Either raise your hand and ask your question, or ask your question without raising your hand, or just post it on the chat. Any comments or thoughts, ideas? I'm impressed by you know, how all the changes you've been able to implement, and you seems, Katelyn, like you used the opportunity, like a moment of crisis, to kind of reevaluate and what you could change to increase the placements of sealants, and it seems like it's working. So congratulations, and thank you for sharing all that, for being here today. Thank you very much.
Yes, and I will say that having the opportunity to be a part of the Sealant Learning Collab with NNOHA really gave some insight on some of the simple changes that you can make within your practice, you know, especially during a hard time where there's limited staffing, you know, maybe things, depending on your office, maybe, you know, making big changes are hard, but making those small changes here and there can really make a difference. So thank you for having me. I appreciate it.
Thank you for sharing all that. Wonderful. So I believe next we had, is it Marie from the Notch was presenting to us?
It is, Deb.
Hey, Marie, one of us also presenting. It's so advanced to your first first slide. Thank you.
All right, thank you. I will start off by saying that in 2019, I attended a NNOHA conference in Las Vegas, and it was one of the best conferences I've been to. I really appreciated it. Little did we know COVID was right after that and all the changes, but I got a lot of the information about sealants from that conference for sure. So my name's Marie Howard, and I am as well a tooth tutor, as you all know. So I work for NNOHA. If you can go to the next slide, Deb. So NNOHA is Northern Tier Center for Health. We just call ourselves NNOHA. We are an FQHC providing medical, behavioral, wellness, dental, pharmacy services to Franklin and Grand Isle counties. Next. So in 1962, in the little town of Richford, a primary medical care office was opened, and that was the only medical facility up in that area. And then in 1994, that office obtained rural health clinic designation. And then in 2002 was the start of that little office becoming an FQHC. Since 2002, we are now 8 health centers, 2 dental clinics, 4 pharmacies. We just last year became a social grocery store because the local grocery store in that area was closing and there was no other options. And so the community health center took that on, and we have 2 day camps, and we're serving over 20,000 patients across Franklin and Grand Isle counties. Next. So these are our 2 dental offices. Richford Dental Clinic, it's a very historic building. It used to be a manufacturing facility. Our dental office takes up close to 1/3 of the 4th floor of that building. The health center, the medical health center is on the second floor. The grocery store is on the first floor. So it's a Notch-owned building that serves a lot of, the third floor is for low-income housing, mostly for elderly people. So it's a very community-oriented. So in our Richford clinic, we have 3 dentists, 4 hygienists, 1 EFTA, and we have 11 rooms. We moved there in 2010, opened as 7 or 8 rooms, and we've now expanded up to 11 rooms. Our office in Swanton is medical and dental combined. The waiting room is for both medical and dental, and just 2 separate check-ins, but it's all within the same window. And they have 2 dentists, 4 hygienists, 1 EFTA, and they have 7 rooms that they're operating with. Next slide. So Candace did a very good job going over this, and I think we all know what the Uds measures are. So yeah, just percentage of children ages 6 to 9 at moderate or high risk to high risk for caries. And then we've got, number of students that are eligible or kids that are eligible, and then how many of those patients had sealants applied. Exclusions, of course, would be if they've had a tooth sealed previously that's still in place, or if they have decay, if a filling's already been there, or if the tooth is unerupted or missing. Next. So I didn't have the 2021 numbers when I put this together. I did write down, Candace said the US number was 67.68, I believe, for national for 2021. But we've seen a steady, well, not with COVID, but but the 2021 numbers were higher than 2020. And in Notch, we have progressively gotten better with our numbers. I was given the task of monitoring all of this for our clinics in 2019. So before that, I'm not for sure how it was all tracked. But you can see this past year, we only had 7 children that were not able to get sealants, and it was mostly patient compliance or the family didn't want it. And then next slide, we'll get into how we do it. So the strategies that we put into place, I have to say, we were paper charts right up until the new year. So it was not easy to capture all of this data. It was a lot of time. What we did was we printed off the ADA Caries Risk Assessment form, and at the bottom of that form, we added teeth number 3, 14, 19, and 30. And we had to write in the date of a filling, the date of the sealant, the date of the exam when we found the tooth was missing or unerupted. It was a lot of paperwork, so we have a really good team that just really helped to collect all of this data. We had the ADA caries risk levels added to the super bill. So anytime a child came through the office, ages 6 to 9, then we had to circle if they were low, moderate, or high risk. And if that didn't get circled, our billing department kicked it back to the hygienist to have it circled. The other thing I think really helped capture everything, so it wasn't so overwhelming at the end, was we ran periodic reports. So every 3 to 4 months, we ran a report as to where are we at currently, and we could tackle some of those with, oh wait, the sealant was placed on this day, or nope, they were in for a filling. And I had to go in and manually input this data into our scheduling EDR system. At first, it was a lot of work, but as we got into the groove, it got easier. And then we ran more reports to verify all of the data. But the biggest way that we got the big numbers or the better numbers was same day sealants. In our office, it's mostly the hygienist. EFTA does come in and help us out if they are free. But the dentists are all on board because we all know sealants work. And I assume, just like most FQHCs, our restorative appointments, I mean, we're scheduling 4 or 5 months out for a filling. Like sealants are a priority, same day sealants, and all of the staff is totally on board with that. Next slide. So challenges, like I mentioned, paper charts was the biggest. Time management, yes, we ran behind by doing this. Missed appointments, of course, no shows, which actually helped with time management in some cases. Patient cooperation, scheduling, same-day sealants just helped because we were worried about no-show rates with rescheduling patients to come back for sealants. Benefits, I can't express enough. Teamwork. It's just, really good. We have one dentist that would literally like get in and test our sealants and try to pry it off. And if it came off, we had to reseal it right then and there. But same-day sealants. Next. So future plans, we now have a electronic dental record. So we just acquired Dentrix for our office. So I just touched base with our IT department to start running a report to see where we're at, to make sure that everybody's inputting all the data correctly into the system, and not wait until December to do this. Try to check out where we're at right now. We're going to continue with same-day sealants. It's the best way for prevention, and it's what's worked really well for us, and everybody's on board. And continue with the periodic reports, like I was just saying. And that is it. Does anybody have any questions?
Any comments or questions, ideas?
This is Candace. Thank you both for presenting and sharing about your experiences. I wanted to clarify that the 67% for the UDS was only for the state of Vermont in 2021. For national, it was 55%.
So we're doing well. Any thoughts?
Oh, I will say, when COVID hit, we were open for emergencies.
Mm-hmm.
And then as we were able to go back into the offices, we were still waiting for extra oral units and whatnot. So what we did in our office was we scheduled children only for the first like 6 or 8 weeks. And we were doing glass ionomer sealants at the time. The dentists were not big fans because they didn't stay retained. So we have since gone back to resin, but I've actually been in touch with Katelyn, and I'm meeting with her soon because we're trying to get a pilot program started in our schools up in this area too. And we want to do glass ionomer sealants for there.
Great, yes. We are recommending in 802 Smiles that for sealants placed in school settings where you don't have at least where you can't have a dry field, or just wherever you prefer to use glass ionomer sealants. And it's both because of what I just said about the field not needing to be as dry. Also, I've seen research, and I'd be happy to share research showing that for immature enamel, glass ionomer has several advantages. And once the tooth erupts, it takes up to 2 years for the minerals to be fully incorporated into the enamel. With resin, you don't have that because the resin blocks those minerals from coming into the enamel. Whereas with glass ionomer, the glass ionomer promotes mineralization of the immature enamel. In also situations where you still have gum covering part of the molar, you can seal with glass ionomer, but you can never seal that with resin. And sometimes it's too late when the child comes back and the tooth is fully erupted, and then you miss the opportunity of sealing the tooth. So for these reasons, and especially considering the resources needed, we'll be recommending for school settings that glass ionomer be prioritized.
Yep.
But prevention is valuable either way. So thank you all for sharing, your success stories. This was awesome. No one has any questions for for the presenters or comments? We're a few minutes ahead of schedule. I was wondering if everybody's okay with this. Maybe you could stop the recording now. And just stop the